Hi, guys. So I wanted to look through the exam material that I had already submitted and make you a short video that will be helpful to you for the progress test and the comprehensive exam. I will make another video that has all the rest of the things on the outline, but that would be much longer and not something that I wanted to give you like with a time crunch on it. So we are just going to do a short video about bacterial meningitis and viral meningitis, encephalitis, and meningoencephalitis. Okay, so that's all this video is going to be about. All right, that said, first thing we want to talk about is bacterial meningitis. And we already talked in class about how to kind of read and interpret a CSF panel, like what you're going to be looking for in terms of protein, glucose, and opening pressure, and what inflammatory cells are present. Now what we want to talk about is how do these patients present, and also what are the causative agents, what organisms will actually contribute to this disease presentation. So there are multiple infectious agents, and hold that thought for a second because we have two very different groups of patients and they each have different most common causes of bacterial meningitis. So when patients present acutely with bacterial meningitis, they have that severe headache and very stiff neck, remember, where they can't touch their chin to their chest as such. They will also almost always have fever. There's usually vomiting and just severe photophobia. What's on your differential? So aseptic meningitis or viral encephalitis, we're going to talk about those in a few minutes. And also lower down, you have things like intracranial hemorrhage or severe migraine. The way that you can tell bacterial meningitis from aseptic meningitis or viral encephalitis is that bacterial meningitis will often present with this very rapidly spreading petechial rash, which then quickly becomes a purpural rash. So here on this patient is where you see it as kind of a petechial rash, here as well. And this would be the purpural version where all those little hemorrhages have kind of bled into each other. And how do we diagnose this? So the first procedure that's done, as we discussed in class, is a lumbar puncture or a spinal tap. And what we actually see with this is upon performing a CSF gram stain, what you'll see is that there will be bacteria present. I'm trying to see how we can get rid of this stupid bar at the bottom so you can see the bottom of the slide. There you go. Okay, go away. Perfect. You can actually see bacteria present on a CSF gram stain. So this is an example of one. You can see inflammatory cells, but you can also see the little teeny bacterial cells that are pointed out with the arrows. In this case, you can see that they're diplococci. You can also perform a rapid diagnostic test. Usually that's a PCR-based test, but seeing a positive gram stain like that is usually well more than enough evidence to start treating. Cultures are usually also obtained for posterity or in case any microbial susceptibility testing needs to be done. But again, usually that happens sort of after the fact because this is such an acute presentation. Treatment has to be started immediately. Okay, so risk factors for bacterial meningitis are going to differ by agent. So again, hold that thought. We'll get back to it in a second. And the treatment for this is IV antibiotics, and it's critical to consult with the ID pharmacist on this to get the dosing right and the pharmacology right, because you've got about one crack at getting this right. And in addition to that, corticosteroids are usually also administered to take the swelling off the spinal cord and the brain to try to minimize any long-term damage. Okay, so what are the most common causative agents? For children and adults, so these three organisms here, Streptococcus pneumoniae, Haemophilus influenzae, and Neisseria meningitidis. I put the word historically with a question mark here because as you may remember from week 5, all 3 of these are vaccine preventable illnesses. And so as more and more of the population hopefully gets vaccinated, then we will perhaps see other organisms replace these 3 as the most common causes. Alternatively, though, all 3 of these are capsule-based subunit vaccines, which means if we think back to week 5, these are all vaccines wherein there's a possibility that you can select for different strains that aren't covered by the vaccine. So while it's possible that other organisms will replace these 3 as the most common cause of bacterial meningitis in children and adults, I think it's a little more plausible that we have vaccine refractory strains of these 3 organisms and they remain the most common cause, but I just want to make sure that's in your head for future reference. Should somebody come along and say, oh, actually, it's this other organism, 20 years from now. Okay, so strep pneumo, on your gram stain, you'd see this as gram-positive cocci. Haemophilus influenzae are gram-negative bacilli, and Neisseria meningitidis are gram-negative diplococci. So they have a really unique morphology about them in that they tend to exist exclusively in pairs. So you'll see instead of either single cells or just big kind of bunches of cells thrown about, you'll actually see these little sets of pairs all over the place. Okay, so that's children and adults. There is a completely different set of organisms that are the most common causes in neonatal bacterial meningitis. So none of these 3 organisms are likely to cause bacterial meningitis in an otherwise healthy child or adult. However, for neonates, so newborn babies that may or may not be premature, different set of organisms entirely. So the first one is an organism called Listeria monocytogenes. These are gram-positive rods, positive, dark purple, gram-positive rods. For Listeria, you usually see this in newborns that are less than 7 days old. And in addition, as mentioned, you don't see these in healthy adults, but you can see Listeria meningitis in immunocompromised adults. So mostly we think of this as a newborn causative agent, but for immunocompromised adults, that's also on the table. In addition to that, we have Streptococcus agalactiae, sometimes called group B streps or GBS. This used to be the most common neonatal cause. However, it's becoming increasingly less frequent for a reason I'll tell you about in a second. These are gram-positive cocci, and like all streps, you see them existing in chains. This is one that you see in newborns up to 8 weeks of age. So less than a week old, it could be either group B streps or Listeria. If you're looking at a 6-week-old baby, then you're probably more likely looking at Strep agalactiae. The reason why this is becoming less frequent is that in recent years, it's become part of the standard of obstetric care to screen pregnant women at between 30 and 35 weeks gestation for carriage of group B streps. It's not unusual for women to carry group B streps as vaginal flora. And when that is the case, vaginally delivered infants can come into contact with this organism, which puts them at risk for, low risk, but at risk for bacterial meningitis. So what has happened with this screen is that if women test positive for carrying group B streps as vaginal flora, they're treated with antibiotics to try to get rid of that colonization prior to delivering a newborn. And in addition to taking oral treatments earlier on, when they're hospitalized for labor and delivery, they're additionally treated with IV clindamycin usually to try to make sure any group B steps that have grown back are halted in their place. So that's why this is really decreasing in frequency. Lastly, the third and kind of least common neonatal agent is Escherichia coli, which again, nearly all of us carry as intestinal flora. So these are gram-negative coccobacilli, so they're kind of short, chubby rods. And this is usually seen in infants that are preterm or very, very low birth weight. So even as a cause of neonatal meningitis, E. coli is usually only an agent that you usually only see with an infant that is otherwise not healthy. And again, this is something that you see really up through the first 2 weeks of life. Anything after that is less likely to be E. coli. And you could imagine kind of temporally why this would be, because this is an organism that's going to be contacted during parturition, right? So during the process of vaginal delivery. And if it hasn't manifested by 2 weeks, it's probably not there, and it's not going to. Okay, so those are our bacterial meningitis causes. So 6 organisms, 3 for children and adults, 3 for neonates, and asterisk for immunocompromised adults for listeria. All right, so then the last thing we want to talk about in this video are viral causes of meningitis, encephalitis, and meningoencephalitis. Okay, so viral meningitis, you'll frequently hear referred to as aseptic meningitis. That's a bit of a misnomer. Technically, aseptic would mean that there's nothing infectious there. This was originally named, you could imagine, a very long time ago before visualizing and culturing viruses was easy. So what this term refers to is the idea that if you do a gram stain, you won't see any infectious agents there, because viruses don't gram stain and they're far too small to see with a light microscope. But irritatingly, you still see this referred to frequently as aseptic meningitis, but just remember that means viral. There are multiple causative agents here as well, so hold that thought for a second. How does this present? Very similar to bacterial meningitis, in that it presents with a severe headache and a stiff neck, fever, vomiting, and photophobia. The difference is that you don't have that rapidly spreading petechial rash. So what's on your differential? Bacterial meningitis, of course, viral encephalitis. We'll get to those in the next few slides. And again, intracranial hemorrhage or migraine. So how do you diagnose aseptic meningitis? Same story, do a lumbar puncture. CSF gram stain will have no findings on it. So in other words, you won't see any bacteria, you may see inflammatory cells. The CSF will also have pleocytosis. So remember, that means kind of mixed inflammatory infiltrates with lymphocytes and monocytes. For most aseptic meningitis, you're going to see primarily a lymphocytic infiltrate. And of course, the other piece that you would do is a nucleic acid amplification test, PCR test, for certain viruses. You'll see which ones on the next slide. All right, so your risk factors are going to differ by agent. Hold that thought again. The treatment for aseptic meningitis is just supportive care, meaning you control a patient's fever, you control any pressure on the spinal cord and the brain, either with steroids or by draining fluid buildup, and you prevent them from having seizures until they immunologically recover. All right, so the most common causes of aseptic meningitis, at least in the United States, are Coxsackie viruses, echoviruses, and enteroviruses. I would be more specific with species. However, usually that is the level that these are diagnosed at. They're diagnosed at the genus level. And there doesn't seem to be a real big difference between this subgroup of enteroviruses versus this one in terms of who causes meningitis and who doesn't. So risk factors for these three, usually you will see them in children or adults who have some kind of ongoing stress or physical exhaustion. And those are the times when you can identify the risk factors. In many cases, the risk factors are completely undefined. It's strange because you may remember having met Coxsackie viruses and enteroviruses before, in that they cause kind of annoying sore throats and hand, foot, and mouth disease and all kinds of really common nuisancey type of infections. And yet, for some reason, some patients have this presentation of meningitis, but it's not clear who gets that and why, other than this kind of vague connection to stress and exhaustion. So in other words, you may not figure out why a patient who encountered a standard run-of-the-mill enterovirus developed meningitis as opposed to sniffles or an upset stomach, and that's okay. Tons of people have tried to figure it out and have not had much success. So we do have a few uncommon causes of aseptic meningitis as well, and those would be measles virus, so rubeola virus, respiratory syncytial virus. We haven't met this yet. You'll meet it in block 3, but this causes the disease kind of colloquially known as croup. And rubella virus, which causes mumps, which we also haven't officially met yet, other than the vaccine lecture. You will meet mumps in block 3 as well. So for ruling in or ruling out measles, mumps, or RSV, for measles and mumps, you would look at the patient's vaccine status. And in addition to that, you don't usually see rubeola virus or rubella virus related meningitis without that patient also having measles or mumps, right? So it doesn't just present as meningitis. Meningitis will develop on the 4th or 5th day of measles disease or mumps disease. So that's a pretty big tell. For RSV, this is not vaccine preventable at this time. But one thing to keep in mind is that you see active RSV disease that's really like clinically severe in children who are infants up through age 4. And so it's not something you see as a severe pathogen of older children or adults. In addition to that, RSV has the same tell in that you don't have a patient presenting just with RSV meningitis. They'll have the respiratory symptoms prior to expressing the meningitis symptoms. Okay. So now we're going to move to viral encephalitis / meningoencephalitis. So we have a wide variety of causative agents. Again, hold that thought. How does this present? Same early on, same cardinal symptoms, but there are a few extra. When a patient first becomes ill, they have kind of a mild influenza-like illness. Then they progress to having that severe headache, stiff neck, fever, vomiting, photophobia, same as everything we've discussed so far. However, they can rapidly progress to either delirium or ataxia, depending on what part of the brain is most affected. And so they'll either have these behavioral manifestations where they're very confused, they don't know what daytime year it is, they may be hallucinating, things like that, or ataxia, where they'll have just slurred speech and uncontrolled movement and just a lack of coordination in general. So on your differential, you have bacterial or aseptic meningitis. You can also see some of these features with cysticercosis, and you can see them also with intracranial hemorrhage. All right, so once again, lumbar puncture, and you can also do neuroimaging here while you see inflammation in within the brain rather than the meninges. For just encephalitis, for meningoencephalitis, you'd see it in both places. Your CSF gram stain is going to have no findings. Again, no bacteria present. Your CSF will also have pleocytosis, monocytes, lymphocytes usually, and you would also conduct PCR tests for certain viruses. Which one? You'll see in a minute. Okay, so the risk factors are very different by agent. Again, hold that thought. And treating viral encephalitis or meningoencephalitis, really only herpes viruses are going to have an antimicrobial treatment where, again, you would treat with intravenous acyclovir. The others are all supportive care. So again, you're controlling fever, preventing seizures, and controlling the pressure in the brain. Okay, so let's start with arboviral encephalitis. So this first slide here is devoted exclusively to flaviviruses. And as you can see, there are a lot of them. So dengue virus will generate encephalitis, as will tick-borne encephalitis virus, hence the name. West Nile will do it, yellow fever will do it, Powassan will do it, Zika will do it, Japanese encephalitis, again, hence the name, will do it, Murray Valley encephalitis virus, and Usutu virus. All right, I've tried to put these into buckets to help with studying. So everybody on this slide, except Powassan and tick-borne encephalitis, are transmitted by mosquitoes. The only two that are transmitted by ticks are Powassan and TBEV, tick-borne encephalitis virus, which is very conveniently named. Travel history is going to be important for several of these. And of course, you can imagine there are a bunch of maps that I'm going to show you in a second. Vaccine history is important for ruling in or ruling out yellow fever, Japanese encephalitis, and to a very small and unique subset of patients, dengue virus. But by and large, if we're talking about US-based patients, we would be looking at had they been vaccinated against yellow fever or Japanese encephalitis. In addition to that, both dengue and yellow fever can also cause concurrent hemorrhagic fever syndrome. So more on the pathophysiology of that in block 3, but you may also be seeing patients that are presenting with like petechial hemorrhage. All right, so don't get overwhelmed. Here's how to sort this out. First one is easiest. West Nile, endemic virtually all over the world. So travel history is not going to be particularly relevant for West Nile virus. Okay, that's the easy one. Second easiest one, Murray Valley encephalitis, because you only see it in Australia. And in particular, like just the little Victoria province, that's it. It's the one spot in the entire world where you find it. All right. I tie for third easiest between Japanese encephalitis and Powassan and tick-borne encephalitis, but let's start with Japanese encephalitis. All right, so this is endemic in East Asia, Southeast Asia, and India. The reason why it's kind of third easiest is it has a geographic tell in the name. So it's not that you only find it in Japan, but remembering Japanese encephalitis will kind of direct you toward this part of the world. So if you have to remember, there's one that's only found in East Asia, Southeast Asia, and India, it's Japanese encephalitis. Okay. Powassan and tick-borne encephalitis. Each hemisphere gets its own tick-borne encephalitis virus. TBEV is in the Eastern Hemisphere, Powassan's in the Western Hemisphere, with one weird exception that probably has to do with migratory birds. There is this little bit of Russia, like right around Vladivostok, where there are, for whatever reason, Powassan cases that occur, a handful of them every year. And again, I think it's probably related to migratory birds. But by and large, Western Hemisphere Powassan, Eastern Hemisphere tick-borne encephalitis. All right, then we get Usutu virus, West Africa, and then spread into Europe and now circulates all over Europe. Last three, Zika, dengue, yellow fever, between the two tropics, all over the world. Okay, so there are some buckets to put things in. All right. Those are our flaviviruses. Now we have alpha viruses. So we have 3 equine encephalitis viruses. We have Eastern equine encephalitis, or triple E, Venezuelan equine encephalitis, and Western equine encephalitis. Our other 2 on here are chikungunya virus and Ross River encephalitis. All right. Good news is we already met chikungunya, so you know a little bit about this guy. One universal thing on this slide is that everybody's spread by mosquitoes. No tick-borne alpha viruses, at least that cause encephalitis. And travel history is important to all of these, but I'm putting a caveat on Eastern and Western encephalitis. Okay, so we're looking just here for a moment at our equine encephalitis viruses. They do something very convenient in that the Eastern equine encephalitis is found on the East Coast, and Western equine encephalitis is found on the West Coast, which is handy. And then you can also see there's this bit of purple where you have circulation of both viruses in the Midwest. So that's helpful. And then all we have to remember is Venezuelan equine encephalitis virus. You can see not just in Venezuela, but throughout South America and up through Central America. And you can actually see we are starting to see local transmission, Texas, Colorado, Florida, which means it's probably in Arizona and New Mexico too, but just hasn't been officially diagnosed as such. So the equine encephalitis viruses are handy. Chikungunya has been endemic in the Eastern Hemisphere for a long time. So you see it in East Asia, kind of south of Russia. You see it in Southeast Asia, you see it in India, you see it in the Arabian Peninsula, and you see it all over the continent of Africa. We have some grayed out countries here. So you have Botswana in particular kind of sticks out, and to Libya and Algeria. That is probably a lack of data and a lack of measurement of chikungunya activity as opposed to actual absence of the virus. So just think of all of this as being blue. The reason that you have France, Italy, and all of Latin America and the Caribbean colored in orange is because this emerged there in 2013. Don't worry about that date. All we want to know is right now, everywhere basically south of here, and all of China's colored in, but most of the case activity occurs in southern China. Everywhere south of here, you're going to see chikungunya activity. And then the easy one again is Ross River virus, because you only see it in Australia and in parts of Oceania. So you might want to put these 2 slides together in your head and think, all right, now I've got the Australian ones. So we have Ross River virus and Murray Valley encephalitis. And then chikungunya, you could kind of imagine, goes more with the Zika, dengue, yellow fever crowd. All right, so we have 2 more groups and that's it, I promise. Herpes virus, encephalitis, and meningitis. We have 5 different herpes viruses that can cause encephalitis: HSV 1 or 2, CMV, EBV, and VZV. Okay, so herpes virus 1 and 2. The biggest risk factor is being prior known to be infected with HSV 1 or 2. So a person who's prone to cold sores or a person who has genital herpes is going to be at greater risk for herpes viral encephalitis. CMV and EBV, it's plausible that a patient presenting with these may have had a recent influenza-like illness, but not necessary. CMV and EBV really can come completely out of left field as presenting as encephalitis. And then finally, varicella zoster virus. This is a handy one because you can again check vaccine status, although VZV is one of those vaccine preventable diseases where there are strains that circulate that are not covered by the vaccine. So a vaccinated person can still develop disease. However, it's also got that same feature that measles and mumps and RSV do, in that a patient is not going to develop VZV encephalitis out of the blue. They'll concurrently have chickenpox. All right, and our last group are bunyavirus encephalitis agents. So we've only got 3 of these: Jamestown Canyon virus, lacrosse encephalitis virus, and Oropouche virus. All 3 are spread by mosquitoes. Lacrosse virus and Jamestown Canyon virus are endemic in all parts of the US, but they're still fairly rare to actually cause encephalitis disease, but there's not really a particularly unique geography associated with them. However, there is unique geography associated with Oropouche virus. So this is, you have a travel history being important here. And this guy was first found in Trinidad and Tobago, but really it seems like most of the cases actually occur in Brazil and some in the surrounding countries, but mostly this is a Brazil phenomenon. Okay, so what we want to take away from this are who's at risk for bacterial meningitis versus viral. What are the agents of viral and bacterial meningitis? And can you tell them apart from a patient description? So you want to pay attention to things like travel history. How old is the patient? What underlying features do they have? Are they vaccinated against XYZ pathogen? And that should about do it. All right, hope this helps. I'll make a longer video with all of the other agents that were missed, and I'm very sorry to have goofed the timing up on this. I thought I cut enough material out, but apparently I did not. So I'm sorry, and please let me know if you have any questions. Bye.